All right, welcome. Today, we are going on an anatomical detective mission right into the heart. Our goal? To figure out, for good, how to tell one chamber from another, even when the anatomy is a complete and total mess.
So this is really the big question, isn't it? Imagine you're looking at a case of really complex congenital heart disease or just some super confusing imaging, and all the usual landmarks, they just aren't helping. So how do you get your bearings? How do you make the right call? In this explainer, we're going to find the absolute definitive signposts that will always guide you home. So, our investigation starts at the top of the heart with the two chambers that receive all the blood, the atria. You can think of them as the two front doors to the ventricles. Now, they might look kind of similar at first glance, but they have some really distinct features that totally give them away if you know what to look for.
Okay, so let's break down the key differences here. If you look on the left, you've got the right atrium. It's defined by that muscular ridge you see, that's the Crista Terminalis, and it has this really broad, almost triangular-shaped appendage. But then you look over at the left atrium on the right, and it's way smoother. And look at its appendage. It has a much, much narrower opening. These are our first big clues.
Let's really zero in on this thing, the Crista Terminalis. It's this muscular ridge that runs right between the two big veins, the vena cava, inside the right atrium. And here's the absolute crucial point. This is a completely normal piece of anatomy. On an exam, this is a classic trick. They'll show it to you and suggest it might be a blood clot or a tumor. Don't you fall for it.
Now, the right atrium has a few other little secrets that love to pop up on tests. You've got the eustachian valve down by the inferior vena cava, or IVC, and sometimes you'll see this lacy web-like thing called a Chiari network. But pay special attention to the coronary sinus. It's the main vein that drains the heart muscle itself, and it's not just a landmark. It's also the path you take to place pacemaker leads on the left side of the heart. Super practical to know.
Okay, let's move down to the heavy lifters of the heart, the ventricles. Now, the atria gave us some pretty good clues, but when we get to the ventricles, we are looking for one single, absolutely reliable feature that tells us which is which, no matter how scrambled the rest of the anatomy is. You know, this quote from our source material just says it all, doesn't it? A little blunt maybe, but it gets the point across. It asks you to picture a massively messed up congenital heart, where you have to know which chamber is the true right ventricle. I mean, this isn't just a fun academic puzzle. In a real person, getting this right is absolutely critical. So, what's the secret?
And here it is. The solution, the one true signpost, is the Moderator Band. This is your anchor. This is the feature that when you find it, lets you point and say with 100% certainty, that is the right ventricle.
So what exactly is this thing? Well, the Moderator Band is a special band of muscle that is only found in the right ventricle. It's a super consistent, super reliable landmark, and it actually contains part of the heart's electrical wiring. In the world of cardiac anatomy, the presence of the Moderator Band is the definition of a right ventricle. End of story. Period.
Okay, let's switch gears a little. We've been talking pure anatomy, but now let's talk about how we actually see these things. We are entering the world of cardiac MRI, which, can sometimes feel a bit like magic. And our source material has this perfect and hilarious analogy for it. I absolutely love this analogy. It just perfectly captures that feeling of intimidation when a super complex cardiac MRI case gets thrown up on the screen. But hey, don't worry. That's why we're here. We're going to pull back the curtain and make you a cardiac MRI wizard today. First up, the two-chamber view, or, as we're going to call it, the basilisk fang view. And you can totally see why it gets that name, right? It has that long, curved, fang-like shape, showing you the left ventricle and the left atrium. So what's this view actually good for? Well, it is excellent for checking out the anterior and inferior walls of the left ventricle, getting a look at overall LV function, and for evaluating the mitral valve. And here's a little bonus exam tip. This is a view where they might ask you to point out the coronary sinus, which you'll see in cross-section. Our next piece of imaging magic is the four-chamber view, which slices through the heart kind of like the sword of Godric Gryffindor. As you can see, it lays all four chambers out for you at once, both atria and both ventricles. The big power of this view is that you can assess both the mitral and the tricuspid valves at the same time. Now, it's generally not the best view for most congenital heart problems. But, and this is a big but for exams, there is one major exception, the AV canal defect. That's a hole right in the center of the heart, and it's seen best on this four-chamber view. And last but not least, we have the three-chamber view. The source amusingly calls this one an impure hybrid because it's sort of a mashup of the four- and two-chamber views.
What you get is this great long-axis view that includes the left ventricle, the left atrium, and the aorta all in one shot. So, for this view, you just need to remember one thing. It's one huge strength: visualizing the left ventricular outflow tract, or LVOT. That makes it, without a doubt, the absolute best view for looking at blood flow across the aortic valve. So if you get a question about the best view for aortic regurgitation or stenosis, this is your answer. All right, let's step out of the high-tech MRI wizarding world and go back to something a bit more traditional, the good old chest X-ray. Now, the source is pretty blunt that a lot of these classic signs are, well, not so reliable in the real world. But, and this is important, they are absolutely testable, so you gotta know them. This table lays out all the classic signs for you, and you can definitely pause and take it all in, but let's really focus on the left atrium, because that's where the most famous signs live. So on a frontal X-ray, you might see the carina, that's where the windpipe splits, splayed out to more than 90 degrees. You could also see what's called the double density sign. Then on the lateral view, you look for the walking man sign, which happens when the bronchus gets pushed backward. Okay, for our final section, let's just quickly cover a few anatomical mimics and oddities. These are the kinds of things that can pop up on imaging and just throw you for a loop if you're not ready for them. First up is the echogenic intracardiac focus. It sounds complicated, but it's basically just a bright spot, a tiny calcification on a papillary muscle that you see on a prenatal ultrasound. Most of the time, it's totally benign, means nothing, and goes away on its own. The key takeaway, though, is its known association with an increased incidence of Down syndrome, so it's considered a soft marker that just means you should take a closer look for other signs. And this slide is great because it clears up a really common point of confusion, telling the difference between a true cardiac lipoma and something called lipomatous hypertrophy of the atrial septum. A real lipoma is a rare, encapsulated tumor. The hypertrophy, on the other hand, is way more common. It's just a buildup of fat. The key difference, as you can see, is that the hypertrophy spares the fossa ovalis, giving it this classic dumbbell shape. It's also seen in older, heavier patients, and since it's made of brown fat, it can actually be metabolically active, meaning it will light up or look hot on a PET scan. So after all that, after covering the atria, the ventricles, advanced imaging, and all those anatomical mimics, we come right back to our central theme. We've looked at a ton of clues and signs today, but I'll leave you with this question to think about. What is the one definitive anatomical signpost that you will now never, ever forget when you're faced with a confusing